Uh, you can see the short history. This is a newly diagnosed patient with prostate cancer, and this is a bone scan. Two views, whole body. One, this is on your left is the anterior view. On your right is the posterior whole body view, and you can try to interpret it.
Okay. So these are the MTV bone scan, anterior and posterior images, and it shows multiple areas of increased radiotracer uptake in bilateral rib cage, in the spine, and also in the left sacroiliac joint, and there is also increased radiotracer uptake is noted in the left femur, and based on the history and kidneys, they are also excreting the radiotracer uptake. Based on the history, the most likely these are the osteoblastic mets from the carcinoma of prostate.
Yeah, so you're right. These are metastases. Just a few observation uh, on the basis of these images. While you can almost certainly say that these are metastases, what you cannot certainly say that these are osteoblastic metastases,
Oh yes.
because osteoblastic is a terminology that you would only use when you have the X-rays in front of you, and if you see sclerotic changes at some of these sites or
So
all of
sorry, it
these
was
sites.
used mistakenly because carcinoma prostate just
Yep.
carcinoma
Yeah,
prostate.
you're right that statistically speaking, these are most likely sclerotic metastasis. But do remember that not all the prostatic metastases are always osteoblastic. So this is widespread bone metastasis. You did mention about the excretion from the kidney. Remember that kidneys would be seen normally, so there would be excretions from the kidney, and that's why, if you remember, these scans are mostly done at least approximately 3 hours after the injection of the MDP. So that basically clears the soft tissue, ex- causes excretion to the kidney, and then you have a more preferential uptake in the bone.
Sir, actually I mentioned kidney because I just wanted to mention that this is not a super scan because
This is
I
not a
was
super
just
scan. I got that point. So that's an important distinction to remember. But do also remember that if these images are acquired not after 3 hours, but for some reason beyond 4 or 5 hours, the kidneys can be more faint. And
okay.
then just using that one distinction to separate from the super scan may not always be the very good strategy. So we'll come down to that in a while. Uh, Somebody has asked in here, won't the lytic metastasis would be photon deficient area? Uh, it's not really true. What causes increased uptake on the bone scan is the osteoblastic activity. So even with the lytic metastasis, you have the osteoblastic activity in the surrounding bones, and that leads to the increased uptake on the bone scan. Now, certainly, if we have a very large osteolytic lesion, they may occur as a photon deficient, or what we call as a cold area. So in some scenarios, certainly that could be true, but a lot of the smaller osteolytic lesions can give rise to very intense osteoblastic repair, and that can lead to increased uptake on the bone scan. Okay, good question. And somebody has asked, what is this over the urinary bladder? Now, depending on which department the study is being done, the nuclear medicine technologist, when the patient is not able to empty the bladder completely, they would put a shield over the urinary bladder to reduce the count from the urinary bladder. And the reason is that if patient has not been able to excrete, empty the urinary bladder, and they have a lot of counts can come from the urinary bladder, and that can reduce the count from the bone, because most of these studies would be done either on the fixed time or a fixed counts, and especially if you are doing it uh, on a on either of them, especially on a fixed count basis, because most of the counts can come from a distended urinary bladder. The bone uptake can artifactually be reduced, and that may not be a good strategy. So often these would be shielded. So what you are looking here is a shielded urinary bladder primarily. So this is on the
Is it
AP.
called as it's a question?
Yeah, sorry, go ahead with the question.
So I just wanted to ask whether can we say that it's a masking of the bladder?
It is the masking of the bladder. It has nothing to do with the protection. So it's not a radiological shield. It is just to reduce the counts from the bladder.
Okay, sir. Thank you, sir.
Okay, and you just basically use a metal, a small, any metallic material can be put over the bladder, and that will just reduce the counts from the bladder.
Thank you, sir.
These are the bone scan images of 46-year female patient with known carcinoma of breast, showing there is abnormal uptakes in the multiple vertebral bodies and multiple ribs, and both clavicle and SI joint, and in the both femur. And there is a slight faint visualization of the both kidneys are noted. So I keep it as a super scan, and the two differential on these finding is the number one is it's a metastatic breast, mets from the breast.
Yep. And what was your other differential?
Other as in the case of super scan is a metabolic causes, which is less likely in this scenario.
Okay, so just a point of clarity. When you start to see this focal, fairly discrete areas of increased uptake, the pattern would not be of a super bone scan. So these would be just widespread metastasis. The pattern is different from the previous one because the size of the metastasis and the degree of osteoblastic repair that leads to increased uptake varies from patient to patient.
Okay.
So, but the key to remember is whenever you can see discrete, multiple, randomly distributed focal areas of increased uptake in patient with known primary tumor, that's just metastatic disease. That's not the scan that we will call super bone scan.
Okay.
Yep, you have a question?
Yes, sir. I have a question. If there is a case of super scan, and if we see the symmetrical uptakes only in the ribs, what are the differentials for that case? I have a case. Yes, I have a case in the exam, but I can't take it.
Sure. So let's get to this case.
Okay. There is diffuse uptake in the vertebral bodies and both SI joint, both iliac bones, SI joints. It's all and clavicles and symmetrical uptake, and this is there's no visualization of the kidneys and bladder. So it is a super scan.
So this is the super scan. Yes. And can you make out the distinction with the previous one? So if you look at the ribs in particular on this end, can you appreciate this heterogeneity in the pattern of uptake?
Yes.
And there may be a few focal areas, but they are not well defined. They are not discrete. And there is a fair bit of an heterogeneity. And when you even look at the long bones, you probably can appreciate a bit of a heterogeneity, something becoming focal, but not really focal. Yes. Kidneys are completely not seen. Urinary bladder there is no shielding, but you don't see the urinary bladder. And likewise in the long bones in the legs too, you have an uptake which is much different from that normal uptake that we saw previously. So this is what we call the super scan. No, you rightly pointed out previously that super scan can have this appearance can have multiple differential diagnoses. One is the metastatic disease, the other could be a metabolic bone disease. And as I mentioned previously, if you're just having a delayed scan after 5 or 6 hours,
Yes.
you where there is soft tissue clearance is extremely good, you can have that kind of a picture. So again, the clinical context, the timing of the scan, and all those information would be very important. Now, there are people use some features to differentiate between metabolic super scan versus a metastatic super scan. And one of the features that often has been used is the uptake in the skull. Now, in a metastatic bonus super scan, you may not always see diffuse uptake in the skull, but in a lot of the metabolic super bone scans, you would see very intense uptake in the skull. However, my teaching always, and I always say that you don't make the diagnosis on the images also. You
Okay.
always look at the clinical history, need to know the lab. If you are in an exam setting having a problem differentiating between whether it could be metabolic or metastatic, ask for the more detail about the history, ask for the labs. That all would always be helpful.
Okay. Okay.
So approach in exam would always be, if you are stuck up, think number one, the clinical context. Think number two, do you have an access to the lab? Often what we do in the exam, you don't ask for information from your examiners.
So I'm provided with a nuclear bone scan of a 62-year-old female. These are the anterior and posterior images. I'm able to appreciate that there is a slight increased tracer uptake in the region of the right bilateral renal pelvis. However, the renal cortical outlines are intact and normal. The bladder is normally showing normal activity. There is uh, two increased tracer uptake areas in the bilateral epiphyseal region of the upper limb, and one focal uptake in the region of the metaphysis in the left humerus. However, the sternum is revealing normal activity. The entire vertebral bodies appear to have normal tracer uptake. The lower limbs are also okay. The ribs are also symmetrically normal, and similarly the skull is also normal. So as the patient is having a newly diagnosed carcinoma breast, this focal single lesion in the left humerus can be a metastasis, but I would like to also have a look of the plain x-ray of this patient if it is available. And as such, the rest of the skeleton is not bad. So it can be even some other pathology, the focal lesion. It may be not related to the CA breast.
Okay, very nice interpretation. Uh, Again, you are rightly pointed out some of the features which basically falls within the realm of normality or normal variation. So a bit of a uptake at the pelvic rhetoric junction of the renal pelvis could be just a dilated renal pelvis, bit of a hold up, normal, don't worry about it, even if they are asymmetric. Of course, if you have some previous imaging, you can go and look at the ultrasound or any previous imaging or CT scan to see if there is any pathology. But generally, renal pelvic uptake is considered normal. So you be aware that what you are pointing out here, this is the uptake uh, in the acromial process. So generally, again, it would be normally seen and often very symmetric. Uh, and likewise, when the patient gets a little bit above 40 years of age, you tend to see uptake around the joints because of underlying osteoarthritic changes. So, and while they can be symmetrical, they can also be asymmetrical. So again, the distribution of the uptake and try to localize exactly are they involving the bone or the joint, which often can be on a bone scan, can be a bit challenging, is important to differentiate between the normality and abnormality. Generally, the protocol would be if you see a focal uptake on a bone scan, often um, they would acquire more what we call the spot images. And
Yes, sir.
basically, and that's primarily to look again where the pathology is located, is cortical based, it is medullary based. So having more views, additional views, spot images can sometimes be helpful. But you are rightly said that this uptake could have a very large differential diagnosis. And you ask for an X-ray, so I have to show you the X-ray, and then you have to make the
Yes, sir.
diagnosis for me.
Yes, sir. Sir, this is the plain radiograph of front projection of the left shoulder joint, sir, which reveals the arc and ring, a pattern of the calcification in the left metaphyseal region in the medullary cavity. The joint space, however, appears to be normal. There is the cortex is intact. There is no abnormal periosteal reaction or other lytic or sclerotic lesions. So the appearance is more pathognomonic of an infarct, a bone infarct. It can be secondary due to if a patient has been taken any chemotherapy. So it can happen due to the side effect of the chemotherapy, or it can be an enchondroma as well. So
Yep.
for that, for the differentiation between bone infarct and enchondroma, the definitive diagnosis can be only made on an MRI. Which will, if it is showing fats, so it can be likely a bone infarct, or otherwise the enchondroma will have the cartilaginous matrix and the cartilaginous pattern of the lesion.
Yeah, very good.
This is the two bone scan images are provided here, the anterior and posterior images of an 85-year-old female who has history of a backache following a fall. There is an asymmetric area of increased uptake in the left rib cage in two consecutive ribs, with the bladder is not outlined. However, the both kidneys reveal normal tracer uptake, and the lower limb bones, the upper limb bones are also appearing, looking normal. So the only abnormality that I'm able to differentiate is with this asymmetric uptake in the rib cage, more towards the posterior lateral side near the fifth to eighth rib, likely. So it can be due to a fracture, or it can be yes, sir, it is showing the activity, so it can be a healing fracture due to callus formation. As the upper limb activity is a normal side, and similarly the both epiphyses are also showing the normal activity in the upper limb. So my differentials for this appearance is a rib fracture, and I would like to compare it with the X-ray images also, if they are available.
Okay, good. So what I'm trying to emphasize on these in this study is even when you see multiple focal areas of increased uptake on a bone scan, they at best remains a non-specific finding, because fractures can also give rise to multiple areas of increased uptake, like metastasis or like any other pathology of the bone. So any abnormality, skeletal abnormality on a bone scan would give rise to increased uptake. Or if there are multiple abnormalities, it would give rise to multiple increased uptake. So distinction, history is very important. Some patterns are very important, as you rightly pointed out. If you see this increased uptake, you can see that some of these are almost in a linear pattern, and that is the pattern of the fracture. Metastasis, remember, they would be randomly distributed. Yes. If you look at the anterior aspect here, at the costochondral junction, you just see this series of increase. So series of ribs involved, and that kind of pattern is fairly very typical for a fracture. One significant abnormality that you missed, there are two actually. You said that bladder is not visible. Bladder is visible, and this is the bladder here. So again, that spectrum of normality becomes very important. So this was the bladder is seen here. Now, an important finding that you missed was this increased uptake in the sacrum, the body of the sacrum, and bilateral sacral ala. Now, for that, we just go back and look at this normal bone scan.
Okay, sir. Yes, sir.
So if you look at the normal bone scan, you do see increased uptake in the sacral ala, but generally in the body of the sacrum, there is no increased uptake. And if you note here, coming back, you see this uptake here. And this almost, if you stretch your imagination, and as a radiologist, you probably are all used to stretch your imagination a bit. This is what we call Honda sign at the edge of the insignia of Honda. So this is basically a fracture involving the bilateral sacral ala and the body of the sacrum. And this is one of those insufficiency type of fractures that can be seen in an elderly patient or patient who may have a localized radiotherapy to the pelvis, and they have a more weaker bone, and then they get this H type of fracture. That you don't always get this H shape. Sometimes it can be just incomplete H, but that history becomes very, very important. There is also this focal uptake in the right humerus proximally, and this was another fracture on this patient. So clinical correlation followed by radiological correlation becomes extremely important. Now, I want to take one exception of what you made about the healing fractures. Now, these the bone scan after the fracture becomes positive within 24 to 48 hours. So increased uptake can be seen within 24 to 48 hours. So very strictly speaking, those are still not the healing fractures. The healing probably would not have started in that point in time to say that. So we just say these are recent fracture rather than to use the terminology of a healing fracture. We cannot make that distinction between a healing or a healed fracture because the degree of uptake just reduces a little bit. But important to remember is that the bone scan would become positive after a trauma within 24 to 48 hours. 48 hours generally takes in people who are more osteoporotic or old, but in a younger adult, the bone scan would be positive within 24 hours after the onset or after the trauma. Is there any question that I missed about the previous
Sir, one question is, no sir, previous study, no question left. Sir, in this case, there's a question asked, does old fractures take uptake or not?
So old fracture continue to take uptake till the healing is complete, which means till the osteoblastic repair is going there. And then again, that would again depend upon the degree of immobilization. So till at least for 3 to 4 months, you would see some degree of uptake at the site of the fracture. Though as the fracture gets old, the severity of uptake or the intensity of uptake is gradually going to lessen. But you can still see some degree of uptake in fracture as old as a couple of years sometime.
I'm presented with X-ray frontal and lateral projection of the forearm, hand, and wrist. In the given images, the history is that of the fall on outstretched hand. In the given images, I'm able to appreciate that there appears to be a lucent line in the scaphoid, which has no cortical margination, resulting in cortical break, suggestive of giving the suspicion of the fracture of the scaphoid.
Okay, so let's leave it there. Now let me tell you what happened with the patient. So this X-ray was reported normal, and patient was sent back from the emergency department with some painkillers. He continued to have some pain, and about 7 days later, he came back with continuous pain, and this time he was referred to an orthopedic surgeon for the cause for the pain, and then he was sent for a bone scan. So, and I'm going to show only one view of his bone scan. So you have the right hand, wrist and hand here, and the left wrist and
Right,
hand.
sir.
And this is the delayed image a week after this history of trauma.
So there, I'm presented with bone scan, and there appears to be abnormal uptake. I think it's a little away from the carpal bones.
Mm-hmm.
So I'm suspecting that it is at the lower end of the radius.
Mm-hmm.
So and also in the retrospective X-ray, I think there appears to be a radiodense line, which might be suggestive of some depressed fracture, sir.
No, I actually probably this X-ray was read properly. This is a normal X-ray. Remember, this is a young plate which has fused, and still you see this sclerotic line out here. So this is not any impaction. This probably was read properly. We don't see on a lateral view, even retrospectively go back, and we really don't see much. The pronator quadrant can
To repeat the X-ray after 1-2 weeks, then
yeah, so that could be the other approach. And especially if you have thought about a fracture in the scaphoid, you don't send the patient back without the cast and immobilizing. But and in that case, certainly you are right. You will repeat the X-ray after 2 weeks and evaluate. This patient has presented earlier than that, and this was a distal radial fracture. So out in Australia, we often do a lot of bone scan for indications which may not be the mainstream indication, which is basically a radiologically occult fracture. We don't do it in an immediate setting. Remember that if I do bone scan within 24 hours, I get a false negative bone scan because abnormal uptake may not be seen. But if your patient presented back and you continue to have pain after a few days, bone scan would be a very good strategy to look for those occult, radiologically occult fractures, not only at the wrist, any part of the body. Radiologically occult fractures can be found on the bone scan. Certainly, you would see them very clearly on MRI earlier than bone scan, actually.
Right, sir. Right.
Okay. Let me just explain to you. This is the right side. This is the left side. This is again the right elbow. This is the opposite left elbow. Right elbow out here, left elbow out here.
Okay. So I'm presented with multiple projections of MDP bone scan focused on the elbow, on the both elbows of a 10-month-old child who presented with history of the fall a week back. These images, I can see there is area of increased activity is noted in the region of elbow joint on the right side, predominantly in the ulna, coronal process of ulna. This activity is not seen on the contralateral side. However, I can see in the rest of the images, I can see physiological uptake is noted in the epiphyses on the both sides, on the distal radioulnar joint. However, this area is not seen in the left side, so it could be any fracture, which was
okay. Fair enough.
After the one, so comparison with the X-rays.
Yeah, so there is. You're right. There is a asymmetrical increased uptake on the right side, and the uptake is more localized in the proximal ulna. I probably won't just say it is only localized to the coronoid process. It probably is localized on the olecranon, whole of the proximal ulna, and also extending into the proximal metadiaphysis. If you look, important to remember this normal physiological uptake at the growth plate in the young adult till the growth plates are fused. So it's very important to always look for an asymmetry, because when you have a growth plate injury and if you have any Salter-Harris injuries, you would see that asymmetry in the uptake. But do also remember the bit of an asymmetry could be within normal limit, particularly if you see a slightly increased uptake on a dominant hand or a dominant leg. So that is an important distinction to remember. While normally it should be symmetrical, sometimes the dominant hand or the dominant limb the physis may show a relatively increased uptake, but then you would be seeing that on all the joints, not only in the one that where you are suspecting an injury.
Right, sir.
So this patient probably most likely to have an proximal ulnar fracture. So let's go back to the X-ray, which was reported normal. And now we have seen where the abnormality is present. So can retrospectively,
Yes, sir.
we
This is
can
the
be
X-ray
any
lateral
clever.
projection. Lateral projection of the same child. In this X-ray, I can see there is anterior fat pad is elevated, which can be a normal. However, I cannot appreciate the posterior fat pad. Moreover, I can say the lucent line is noted in just below, behind the olecranon process. Yeah,
Yep.
this is it could be a non-displaced incomplete fracture.
Yeah, and that probably was read normal because thinking this could be just an unfused
Yes,
physis here. Bone scans, both of the lower limbs, and both patients are army recruits, and they have pain in the shin, one only on the right side, one has bilateral shin pain.
Okay, sir. The first one image is of 21 years old male, showing at least two areas of increased radiotracer uptake that is of intense degree on the right tibial shaft. Sir, it can be due to the stress fracture.
Yep. Good.
Okay, and the another one is a 20-year male. Another, okay, bilateral shin pain. There is a slight increase uptake is noted along both the anterior tibial shafts, both right and left. However, it appears normal to me.
So
generalized diffuse uptake as well as increased tracer uptake in both knee joints and ankle joints as well. So the second one, I'm not getting, sir, it.
Sure. So, yeah, you're right about the first one. This is without any problem. This is a stress fracture. There's two focal areas of uptake. The second one is a little bit trickier. Do remember the normal uptake should be uniform. Now, if you look at the proximal and distal tibia and you look at this portion, this is more increased uptake in the and then uptake decreases below and above this. So it cannot be a normal uptake. It is slightly more on this on the left side than on the right side. So this is also a stress fracture. This is of a more low grade stress fracture. This is a high grade stress fracture. Now, if you do an MR on these patients, these would be the patient where you would see decreased uptake on T1 and increased uptake on T2 weighted images. When you do the MR for these patients, the T1 weighted image are more likely to be normal, while on STR images or T2 weighted image, you are going to see increased signal. So it's just those different grades of stress fracture which have been defined on MR also have been defined on bone scan. So just different severity. So the clinical context becomes important. Remember the radiology, X-ray in both cases may be completely normal, especially in the first 2 to 3 weeks after the onset of the pain. Not beyond that, but that. So in first 2 to 3 weeks, X-rays can be false negative when you are suspecting a stress fracture.
Okay.
So there's a question: how can we differentiate these fractures from shin splints?
Shin splint is a clinical diagnosis. And generally, the bone scan would largely be unremarkable on there. Or if you are doing a 3-phase bone scan, you may see some soft tissue, some uptake in the soft tissue phase, but generally on a delayed phase, you don't tend to see any increased uptake. And I've been told time and again by my orthopedic colleagues that don't diagnose shin splint on imaging. it is a clinical diagnosis. So I take that part very seriously. So I don't try to diagnose chin splint uh, on any kind of an imaging. I will show you this VQ scan. So this is a planar VQ scan. The first row and the third row are the ventilation images. The second and the fourth rows are the perfusion images, and the comparative images are here. So this is the posterior ventilation, posterior perfusion, anterior ventilation, anterior perfusion. So these two images are paired images. So you can have a look and make your interpretation.
Okay. Sir, I'm provided with multiple planar imaging of the right and left ventilation and perfusion scans of the both lungs. And I can appreciate that in the ventilation scans, there is no any ventilation defect noted within right and left lungs. And however, in the perfusion scan, I can see that in the left lung, in both lungs, I will start with the left lung. There is a moderate photopenic area, which is segmental, and it is a segment uptake of mismatch not seen on the ventilation scan and defect seen on the perfusion scan within the right lung. It is wedge-shaped and larger. So these are multiple segmental areas of ventilation perfusion mismatch in both lungs, suggestive of high probability of pulmonary embolism.
Yeah, good. So just, I think a point, you're right, there are multiple areas of perfusion defect. Now remember that this is a posterior view, so this is the right lung, this is the left lung. This is the anterior view, so this is the right lung, and this is the left lung. So you probably was mentioning this larger defect to this one. So this is not in the, excuse me, this is not in the right, in the left lung, these are in the right lung. So you have this larger defect here, but you also have a defect here. You also have a defect in the left upper. And when you compare, there are multiple defects. So this is pulmonary embolism. And this is a high probability by this bookish criteria. Now, I don't know what's the practice in Pakistan, but in Australia, we try not to use the probability anymore. We just want to say it is pulmonary embolism, it's not pulmonary embolism, or it is indeterminate. Because
yes, but theoretically, we remember that practically it is very difficult to apply.
Yeah, look, but bookish is what you are saying, which is multiple segmental areas of mismatched defect. That is high probability of pulmonary embolism. If you have one single area of mismatched defect, that would become a low probability. But again, yeah, you always have a much more false negatives when you are interpreting in that way. And in reality, nobody, as a clinician, you don't want to hear probability business. My respiratory colleagues tell me it is there or it is not there. So this hedging in imaging is, we should try to minimize as much as we possibly can. So if I show you the CT, just an image of a CT scan which was reported normal.
Okay, sir, I'm provided with single axial image of CT chest with contrast with mediastinal window, and I can appreciate that it is a filling defect noted within the segmental branch of the right pulmonary artery.
Yep.
So this can be a thrombus.
So this was there, and this was retrospective again. Prospectively, we certainly was missed by us. Retrospectively, after looking at, and retrospectively, you can always be very clever. Normal VQ scan is symmetrical. So these reduced uptake that we are, where there is no uptake of radiopharmaceutical because of the presence of the thrombus, that is the defect. And if you compare this with the ventilation, which is normal. So it's the reduced uptake which is abnormal on perfusion. And so when we say perfusion defect, we are talking about these areas of reduced uptake where my arrow is. And when you compare with the contralateral side, on the ventilation scan, you see the normal ventilation in that region. Does it make sense?
Yes, sir. And they are asking what are the darker areas on the perfusion scans? Corresponding darker areas.
So, okay. Now, the corresponding darker areas, if you're talking about this area here, is that the question is?
Yes, sir. Yes, sir. And
Okay.
in anterior perfusion as well.
In the anterior perfusion you're talking about here. So
Yeah.
remember
Yes,
that
sir.
when you do the perfusion scan, you inject the radiopharmaceutical. And in the hilar region, because of the clogging of the pulmonary artery and veins, you would have an overlapping of those vessels, and there could be a little bit of an asymmetry in the central portion of each lung, which basically just an artifactual because of the overlapping and some trapping of the perfusion material in that site.
Okay, thank
History, which is that patient's blood hormone levels is telling that they have elevated serum FT3 and FT4 and low TSH. So biochemically hyperthyroid.
Okay, I'm provided with a spot image from thyroid scan, in which I can appreciate that there is a dense increased uptake of radiotracer in bilateral lobes of thyroid gland and isthmus region. Thyroid glands, they appear homogeneously increased radiotracer uptake with the increased size of the slight increase in the size of the glands. So this may suggest underlying Graves' disease?
Yep, good. So this diffuse increased uptake, homogeneous increased uptake, that is in a setting of hyperthyroidism is Graves' disease. What is this structure that this arrow is pointing to?
This is thyroglossal duct, the normal descent of thyroid tissue.
No.
This could be the pyramidal lobe.
This is the pyramidal lobe. And often in a Graves' disease, normally you don't see the pyramidal lobe in a normal thyroid scan, but when there is very intense increased uptake, you can see the pyramidal lobe. So that could be an indirect indirect indicator that patient has a Graves' disease. And what this arrow is pointing to, or what anatomical structure this arrow is pointing to, put it that way. It's not a pathology, just some normal anatomical structure would be there. It could be. So this is basically is supraesternal notch. And why do you put a cursor around here? Because you want to rule out any retroesternal extension of the goiter. So most of the thyroid scan, you would see either an arrow or a marker or something to indicate where the supraesternal notch is. Okay, so same history, and now we have another thyroid scan.
Okay, there is an area of intense radiotracer uptake, rounded, well-defined in shape, in the region of the expected location of right lobe of thyroid, and rest of the thyroid gland shows no uptake of the contrast. So this signifies underlying nodule, hot nodule, which may be due to some underlying thyroiditis, or less likely thyroiditis and maybe a thyroid malignancy. I didn't know.
So remember that one of the rules in thyroid endocrinology is if you have a patient who is clinically hyperthyroid or biochemically hyperthyroid, the chances of malignancy is very low in those patients.
Okay.
So this would not be a malignancy, very unlikely to be. So if in a setting of hyperthyroidism, a nodule showing increased uptake, as you said, this is a hot nodule. So what would be your diagnosis then?
This is a functioning thyroid nodule.
This is a functioning thyroid nodule. This is what we will call, not even functioning, we'll call it autonomous toxic nodule, because the rest of the gland is completely suppressed. Now, if you can see the rest of the gland together with this increased uptake, then you will call it a functioning nodule. We will use the term autonomous because it has suppressed all of the gland. which means what therapeutic implication this patient can have, or what would be
So,
the treatment of choice for this patient to treat hyperthyroidism?
so, so sorry, I could not get your question. What treatment is he taking already,
So
or
what
you are
would be the
asking what?
treatment of choice for this patient's hyperthyroidism?
Sir, sir, lobectomy. Sorry, this particular nodule.
So no, this patient would be an ideal candidate for radioactive iodine 131 ablation therapy.
Okay.
And why this patient is an active candidate? Because radioactive iodine 131 is only going to ablate this portion of the gland, because remember, the rest of the gland is completely suppressed. Now, when this is being destroyed, the normal suppressed gland would take up the normal activity, and possibility of this patient becoming a hypothyroid after the treatment would be extremely low. So this patient would be ideally treated with a radioactive iodine rather than with antithyroid medication or a surgery.
Uh, this is a thyroid scan in which I can see that there is increased radiotracer uptake in the region of right lobe of thyroid in form of a nodule, and another area of focal increased uptake in the left lobe. However, the remaining thyroid gland also shows a slight uptake of contrast. Uh, these imaging findings, they are in favor of um, multiple nodules, multinodular goiter.
Yep. So this would be multinodular goiter, or as somebody has written, plumber's disease. So that name that, so this would be what is called toxic multinodular goiter. Remember, toxic would always come from your clinical and the lab picture. So it's not a radiological picture. You can have a patient with an euthyroid status with the same kind of a picture. So if the patient is euthyroid, you just call it a multinodular goiter. If patient is clinically hyperthyroid, this picture would be of toxic multinodular goiter. Now, this can be treated with radioactive iodine too, but remember, this normal gland, which is showing uptake, would also be ablated in addition to these glands. So the theoretical possibility of this patient becoming hypothyroid would be significantly higher compared to the previous patient where rest of the gland was completely suppressed. Okay, another
So the
patient.
treatment would be a surgery in this patient. Treatment would be surgical and medical.
Generally, remember that you don't operate a hyperthyroid gland. So those patient has to be brought to a euthyroid status before any surgery is done. So in a hyperthyroid stage, the treatment of choice would either be a drug antithyroid medications, carbimazole or umacazole, or propylthiouracil, or if patient is beyond that age of when she is not going to conceive anymore, elderly, middle-aged, elderly patient, if they are female, or if they are male, then the preferred treatment could be the radioactive iodine. But again, there are various approaches to that. There's no one single rule about it. But with toxic adenomas, generally the preferred treatment would be radioactive iodine, just for the reason that we discussed earlier. Okay, so another patient who is also hyperthyroid.
Okay, this is a thyroid scan of a 47-year-old female patient in which there is no radiotracer uptake in the region or expected location of the thyroid gland. No any area of ectopic thyroid uptake. Radiotracer uptake is also noted in the visualized in the given film. So this goes in diffusely low increased uptake goes in favor of keeping in view that the patient is also female. Hashimoto's thyroiditis.
Yeah, good. It would be some kind of acute thyroiditis. So Hashimoto's is one of the form of acute thyroiditis, but that would be some form of acute thyroiditis. So no uptake in an adult patient. Again, remember, clinically, they would also have neck in the pain. They may have fever. They would be a bit tender to palpation on clinical examination, which the other causes that we discussed earlier will not be. So the clinical picture is important. So that is a very classical picture of acute thyroiditis. Now, I probably would like to address one question that come up in the chat, which is about the discordant nodule. Now, the discordant nodule basically refers to a nodule that shows uptake on the thyroid scan, but is non-functioning on iodine 123 or iodine 131 scan. So when there is an uptake, the uptake part for pertechnetate and iodine is same for the thyroid gland. But iodine uptake has one more step. It also organifies into the gland, which pertechnetate doesn't do. And that is a cause for that discordant scan. Sometimes if iodine scan and thyroid scan are discordant, that basically refers to the organification of the iodine in the gland, which doesn't happen with pertechnetate. So because of that, some of those nodules on pertechnetate scan can just show no uptake, while they will show uptake on the iodine 131 because of that organification part. Okay, so that's basically refers to that discordant scan or discordant nodule that somebody has asked.
So another question is, how can we when do we go for iodine 131 or 123 scan?
So remember, iodine 123 scan basically has a low energy, and it is used in lieu of technetium pertechnetate scan. But generally, iodine 131 is more costlier. It has a shorter half-life, and it's not readily available mostly. So most of the scans would be done with technetium pertechnetate. There is no otherwise preference. If you can afford to do an iodine 123, you do an iodine 123 scan. Iodine 131 generally we don't use for a routine diagnostic purpose. We reserve it for therapeutic purposes, either for the ablation of the hyperthyroid gland or for thyroid carcinoma ablation.
Another question is, could discordant nodule be a cause of papillary or focal carcinoma? Can it be occur in that case also?
So basically, when you have a nodule that doesn't show normal uptake either on a thyroid, on a pertechnetate scan or on an iodine scan, they theoretically has 10 to 15% probability of being harboring malignancy. So none of those features, a cold nodule doesn't mean malignancy always, only 15%, but certainly compared to those hot nodules, which almost never give rise to malignancy, cold nodules, certainly 15% of those would have malignancy. And that could be cold either on iodine or on pertechnetate. So basically you don't diagnose malignancy on that. You say, if there is a cold nodule that I see, those would be the ones that I will go and do the FNA on. And your diagnosis would be on FNA, not on solely on a thyroid scan. But certainly if you see a cold nodule on a thyroid scan, whether it is pertechnetate or iodine, you like to do FNA on those. Particularly if you are looking at a gland which is multinodular and you want to select where I have to do, which nodule I have to select the nodule which are cold on either of the pertechnetate or iodine scan.
I think, sir, very well explained. Sir, another question is, how could we differentiate between Hashimoto's thyroiditis and de Quervain's thyroiditis on iodine scan?
You cannot. Both would show reduced uptake. So you have to go back to your clinical picture. You have to go to the labs You have to go to the hormonal assay to make that differentiation. They both would show reduced uptake or no uptake on the scan. So basically, we can say this is thyroiditis. That's probably when you remember when it was called as a Hashimoto's. I said we just call it a thyroiditis rather than putting it a prefix. What kind of thyroiditis? Because we cannot make that distinction solely on a basis of a nuclear scan.
These are two images of most likely these are system EB scan. And there is the history is a goiter with a firm palpable nodule in the left lobe of thyroid. So this is a AP view of the thyroid scan, and there is a well-defined area of low uptake in the left lower lobe, and the rest of the thyroid gland appears normal, and it should diffuse uptake on the skin. And so this is most likely a cold nodule, and I would like to do an ultrasound of this area and correlate with the labs, and the cold nodule usually harbor malignancy up to 15 to 25%, and FNA should be done in this case.
Yeah, good. And just one more point, Harun. So this is a marker which is pointing to suprasternal notch, and so this arrow is pointing to that palpable nodule. So if you put these and two together, you probably can also appreciate that a portion of this nodule, which is cold, has a retrosternal extension. And that's where this marking the suprasternal notch, and also if there is a palpable nodule, marking those nodules on the image becomes important, because if you have a non-functioning nodule, you could very easily miss if you don't know that this is the palpable nodule out here. So when we do the scan, we try to palpate and then put a marker and make sure that all those nodules, if something big is palpable, can be identified. There was a question there about the FNA. Now, the yield of FNA depends upon the expertise of your pathologist who is looking after the slide. So yes, it could be negative falsely at times, but basically, if you have a good pathology services and people who are interpreting the slides are experienced, you will find they could be fairly confident finding a atypical cells there. So yeah, there would, but certainly there is a variability there. But do remember that if you have a very high clinical suspicion based on your age of the patient, the clinical presentation of the patient, what kind of nodule you are, if it's a firm, hard nodule, if there are lymph adenopathy on clinical examination, and all those pictures are highly suspicious for a malignancy, then you don't take that FNA, negative FNA, as conclusive. Either you repeat FNA or you consult with surgery and go for an excision. So that all would be primarily dependent upon the clinical context again.
This is the thyroid. So this is whole body scan I can see, or this is a thyroid scan of a newborn, in which I can see congenital hypothyroidism. I can see that the epiphysis, that there is no uptake in the epiphysis, and there is increased uptake in the region of the thyroid gland, which is well-rounded and localized.
So what do you think is the cause for hypothyroidism?
The hypothyroidism, congenital.
So actually, yeah, you describe it well, that there is a focus of increased uptake here. But if you look at the lateral view, the important
Yes,
thing
sir.
is
It is in the region of the base of
where it is
the,
located.
it is
So this is
located
the head, this is the
in the base
face.
of the tongue, sir.
Your neck is here, and then
Yes,
you
sir.
have the thorax.
Sir,
And
it
you
is at
probably,
the base of the tongue. That is, it may be the lingual thyroid.
yep. So that's what it is. And the key here is the lateral view. It's very difficult to keep the
Yes, sir.
baby
And this I can see
newborn
that it is, yes, sir.
extended to work out where is the neck and where is the. It's difficult, but on the lateral view, you probably can make out the outline of the head, the face, and this narrow neck, and then the thorax starting. So this is a lingual thyroid.
Right, sir.